Yes, welcome everyone. The Learning Ideas Conference, Inclusive Learning Track Session. We are very pleased and many greetings from Cyprus and very pleased to see the fruitful contributions of presenters to this track. First of all, we are going to start with two valuable presenters about the open access learning in a pathway to equity during the health emergency. I would like to introduce Melissa Atias and by giving brief information about her background. Melissa Atias is a global health professional who has been working on the learning and capacity development for health emergency with the World Health Organization since March 2018. She has played key roles in production, reporting, and communication for World Health organizations, Open Online Learning Platform, Open World Health Organization.org, which grew from 6,000 course enrollments before the COVID-19 pandemic to 6 million enrollments today. Melissa previously presented Open World Health Organization exhibitions at the World Health Assembly, Geneva Health Forum, and Platain Saint-Elieu. She has also supported the preparation, implementation, and review for the World Health Organization Health Emergency Program training workshop across the world with a focus on evaluation and reporting. Melissa holds a Master of Science in Global Health from the University of Geneva in Switzerland, where she authored her thesis on the role of social science with health emergency response. Prior to her work with a World Health Organization, Melissa served as a communication analyst for the Stop TB Partnership to raise awareness of the devastating toll of the tuberculosis and showcase work to eradicate the disease. She also holds a Bachelor of Arts in Journalism and Mass Communication from the George Washington University and previously reported on health policy as a journalist for a news organization in Washington, D.C. Very pleasure to present about the Melissa background, and now is the Mrs. Henny Yutunen.
So I can perhaps take it from here. Is it okay? So we don't spend time on the background. I can just shortly present myself and then go ahead with the
Okay.
Yeah, thanks. Okay. Great. Thanks so much, Chairs, and really a pleasure to be here today. I'm Heini Utunen, the head of unit for this learning and capacity development unit of the Health Emergencies program in the World Health Organization. And I've been leading this area of open access learning since 5 years. And this is our openwho.org platform. And I'm together here with my colleague, Melissa Atias, who's presenting together with me. And we are from Geneva, Switzerland, where the headquarters of the Health Emergencies, or the World Health Organization is located at. And in this session, we really want to showcase how open access learning has contributed to the access and equity in the world. And these findings are from the pandemic learning experience during the past 2 years, during which we mounted not only a massive scale, massive number of courses. We have 45 learning courses online, synchronous formats, asynchronous formats for learners. And at current time, we host nearly 7 million enrollments to these courses. So it's been very massive scale. And I'll provide the background on this platform and also where we are heading to. And Melissa will talk about the results in a minute. So we first launched this platform exactly 5 years ago. It was this week, 5 years ago, and with an aim to be prepared for a pandemic. A pandemic wasn't a question about if, but when for the World Health Organization. We knew that the pandemic gonna hit this humankind, but of course, the moment when it started early 2020, it slightly took us by surprise. However, we had this platform that had been designed as part of the pandemic preparedness programs to be ready to upscale the learning content, but also hosting unlimited number of learners. And we had been using the platform for 3 years for very regionalized, localized disease outbreak learning response, such as Ebola, West Africa, Ebola in the Democratic Republic of the Congo, for various diseases from diphtheria and Rohingya's crisis to meningitis in the meningitis belt in the Central African or in Sub-Saharan Africa, and many other diseases. And our cornerstones are really the open access, self-paced formats. It's free of charge, it's in multilingual formats, and it's in multi-channels as well. So the materials can be reached from different devices offline, be utilized in low bandwidth formats in particular. So the learning we are catering is first and foremost for least developed countries and Global South. Here are some key figures. In total, we have soon 7 million learners in 157 different course topics, all from health domain of the World Health Organization. So these are courses that are based on norms and standards of the World Health Organization and translated and transferred into a learning formats that are easily accessible, downloadable, and usable for in particular for health workers in Global South. Out of these 157 course topics, we have 46 COVID-19 courses, so everything from mass gatherings to clinical management, from infection prevention and control to access to treatment facilities, vaccines, testing, rapid diagnostic tests, etc. So we've been producing learning real time as the COVID-19 pandemic evolved, and have been always relying on the science behind this novel pathogen, which is actually a disease X. This is a disease X that nobody knew of before the year shift 2019-2020. And while we had been prepared to respond to a disease outbreak like this, it was a very heavy mounting that we took in the team. Half of our learners go out from the platform with the course certificate, so 3.6 million certificates have been issued. The learning resources are in 64 languages, in 15 languages of the African continent, and these are localized languages like Hausa, Lingala, Kanuri, Swahili, and other languages. And we have 15 most spoken languages of the world as well. We've so far translated 12 million words, and this is a massive operation to take. And recently, since last year, we've been also issuing digital badges of the performance on the courses. These are becoming very, very popular among the learners. The use case on the platform has really changed during the pandemic. So before the pandemic, antimicrobial resistance topic was the most popular course, together with the occupational health and safety for Ebola, incident management system in emergencies, and other resources like risk communications were the most popular. Now, of course, during the pandemic, all the COVID-19 topics and topics like hand hygiene for facility workers have been really the top courses. We do host learning in 28 diseases. Majority of these are infectious diseases. And the yellow ones or the orange ones here are the ones that are diseases with an ability to become the next pandemic. So our really key focus now, as we are trying to come out from this COVID-19 pandemic, is to prepare for the next pandemic, which is very likely to happen in our lifetime. And we are hosting resources for all these diseases, but yeah, you name it, there's gonna be a disease that it can be a new disease X that actually we don't even know of. It's a new disease that we've never heard of, a novel pathogen that just, the same thing. So we all need to be prepared and cautious, and the learning can actually, right time, right avenues, channels, users for the learning, we can actually save lives. And therefore, we are investing on this online learning and trying to do the full effort to reach the last mile among the health workers. To us, the health workers are actually the first mile in all countries in the world. And we've seen from our results that we have quite a crowd of users on the platform. So here's just the history to date. And I said it was this week, 5 years ago, when we first went live with the platform. We've grown exponentially over the pandemic, so it was very busy time. It's been very busy time now in the pandemic, and we've gone from a team of 2 to a team of 20 in this operation, working fully dispersed manner across the world. How this contributes to the equity and access, we've actually, with the platform, we've reached the not so frequent users of health learning throughout the pandemic. So we've increased the number of female learners, the learners who are above the age of 70. At one point we had more than 10,000 learners, 70 plus age learners from Ecuador only. So really those vulnerable to this disease went online and looked for information how to better protect themselves and their loved ones. And we had these resources from early on in all UN languages, but also in other languages. And we also have a significant group of young learners, younger than 20 years of age. 10% of our learners are these young populations, which is also important that we see how this online reaches this kind of a very, not only the active working life age of people. And we've also, other important findings will be presented by Melissa, but for instance, the small islands per capita are contributing to the most of the users when population factor be taken into account. Majority of our learners identify themselves as students. Could be somebody like me, an eternal student, though I'm professional already. We've also asked per courses and found out that in some courses, like currently for Ukraine, that in the learning response material users, half of the users are healthcare professionals. So they're really eagerly coming to our Ukrainian courses. We host Ukrainian language courses in 17 different health topics that are critical now for the situation of the war. And users across the areas, and here you see the evidence of women being now more represented than men, and this has never been the case on our platform, and often the learning is consumed by kind of already aware populations, and here we are really happy that we've been able to diversify from there. I'll hand over to Melissa, who takes it forward.
Okay, great. Thanks so much, Heini. So I just wanted to share some of the results that we found carrying out the platform during the pandemic. So first, we've really found that the learning has shifted from a focus on mostly higher income countries, although we had high case use among countries where they're experiencing outbreaks, like Ebola outbreaks. But with the global shift for the pandemic, we've moved towards more low and middle income country users on the platform. So now that's nearly 2/3 of OpenWHO users compared to half before the pandemic. And this has really been driven by a surge in demand from middle income countries who were affected by COVID-19. This next slide shows a heat map of our country enrollment. So you can see some of the things that Heini mentioned, like if you look at Ecuador, we have a really big circle. This is where we have the highest number of users. And Heini mentioned that we have this big group of senior users in Ecuador. It's also worth noting that Ecuador, they shared our platform with their health professional associations, and this led to a really big increase in users there. You can also see we have a big group of users in Bangladesh, for example. We have a course there on diphtheria, and there was a big outbreak in Cox's Bazar in previous years. So you can see that some of this follows the COVID caseload, and some of this has followed other outbreaks. Our number one country use on the platform is India, where we also have a lot of super users who have taken many, many courses over different topics. So it's an interesting thing to look at. Also, like Heini mentioned, we have a really nice case use in remote communities. We found that among the top 20 countries, territories, and areas per capita, that 16 of the 20 are actually small island states. So one thing we found is that this online form of delivery has helped equity because remote locations are able to participate. And here is a chart of these per capita enrollments. So you can see the top 20 locations of population. You can see our top user is Guam per capita. And then you can see that 4 of these are actually not island states. Ecuador, as I mentioned, which has a really high case use. We also have United Arab Emirates, Qatar, and Suriname, where really high per capita use on the platform.
Can we ask a question on that previous?
Yeah, of course.
What is it that makes countries make it into these numbers? Like, okay, I get some of the third world countries, but I don't get the UAE and Qatar, because these are not countries that are suffering. And what's going on?
Well, so it also depends. So this is the whole platform use based on population. So when you take population into account, they have high numbers. It's not necessarily that they're most affected by an outbreak, but they just have a high percent of the population using the platform. So it could be that they're interested and worried about COVID-19. In the Middle East, we have Middle East respiratory syndrome coronavirus, which has attracted a lot of users. So it could depend on the context. I don't know, Haney, if you want to add.
I'm curious.
Yeah, and then what we've noted during exactly like Melissa says, but also the fact that some countries are really technology savvy. Egypt, Saudi Arabia, the Arab Gulf, the countries from the Gulf are very active in learning online. And then at the same time, for these small islands that actually didn't have COVID-19 transmission until, let's say, after the hurricane, the vessels went to help. This is how, for instance, one of the islands got their first COVID-19 case. So I think these islands also, because of the remote location, they are very keen and used to use online tools. And we actually would need to research more on this, like what is it that kind of, we've been looking at the numbers globally, like how popular online learning is in India. Is it per capita more popular than in UK or Senegal? And there to then also like lay over the kind of facts, like what is the internet penetration, for instance? How much mobile use through apps on learning is being used in sub-Saharan Africa or Central Asia. So we haven't really gone into all of these kind of statistics to run overlay data sets with our own data sets. But I think that's the next way forward when we finally come out of this pandemic. It will be next year earliest.
Thank you so much for the question, and feel free to jump in at any time. It's great. So another area where we've tried to look at our results is that we have a really big emphasis on multilingual learning. We're a global platform trying to help share information for health emergencies with the whole world. And we know that when you're learning in your own language, it's easier for you to learn and understand. So we have given priority to different types of languages. First, we give priority to languages spoken by vulnerable or underserved populations. And we have a partnership with Translators Without Borders, which is a group with a network of translators throughout the world where they help us identify some of these high demand but underserved languages and connect with their network of translators so that we're able to offer materials in those languages. Also, we give priority to languages served by low and middle income countries. Of the 46 least developed countries listed by the World Bank, we currently offer the languages spoken by 44 of the 46, and we're continuing to work to grow this. So it's another priority. Also, we work on supporting special needs audiences. One of the most popular courses by Enrollments on the platform is actually our introductory COVID-19 course offered in Indian Sign Language. This has had a huge use case, and it's been really great to be able to expand knowledge to audiences who aren't necessarily getting it. And also, as Haney mentioned, we have the 15 most spoken languages worldwide on the platform and always continuing to grow that. So here's just a snapshot of the 64 languages we offer. You can see we go from Albanian to Zulu, so quite the list, and obviously it's still many more languages to go of the world. But what's been really helpful during the pandemic is we've also had regional and country offices within WHO, as well as volunteers, reach out to us and say, can we help you get this material in our language? And we've sort of had this crowdsourcing effort, working together with our expert teams where we're able to to expand the number of languages offered. Another thing I wanted to mention, Haney touched on this in the beginning, is that OpenWHO courses are free of charge and self-paced. We really tried to maintain this because we know from our survey findings that the top challenges to accessing learning are people perceive them to be time and cost. And this is especially true for women, which are the overwhelming majority of the health workforce in particular. So we want to make sure that this information stays accessible. I wanted to share this excerpt from the WHO Constitution. So back in 1948, our Constitution included that the extension to all peoples of the benefits of medical, psychological, and related knowledge is essential to the fullest attainment of health. So it's just really interesting and important that this open access idea and then the need goes back to when basically WHO was born. And it's something that a vision we're trying to continue with the open access learning platform. So this morning in the conversation with the panel, we talked about the digital divide. So obviously there are barriers to everyone reaching online learning. So one way that we've tried to build on this is by using multi-use formats. So we've also found we have vaccination courses that have been really popular for COVID-19. So countries understand how to roll out vaccination efforts in their country. And we found among those users, the top barriers to completion were internet and system or IT related issues. And this was particularly true in the global South. So these multi-use formats that we work with are meant to be able to be used both online and offline. For example, we have an app for OpenWHO that you can download all the materials for the course when you have internet, but then it will be on your phone at the click of a finger for you to access when you no longer have internet. We also have slides that can be downloaded, and people actually have printed them and shared them and used them for their own trainings. So just this emphasis on making sure the materials can be used no matter what kind of connectivity you have. We also have low bandwidth adjusted materials. So for example, our videos can be streamed. They can be downloaded in high definition, low definition. They can have just the audio. They can have transcripts. So really trying to make sure that no matter what level of access you have, you're able to see the information. And I wanted to close by looking at what we call the learning multiplier effect. So we tried to actually document some of these instances where OpenWHO materials have been used outside of our platform context. And we found some really interesting examples. I'll just highlight a couple of them because we have 20 here that we've shared. But for example, field worker training, we found in Guinea-Bissau that material was used for field worker training on clinical management multilingually. So it was printed for in-person use, like we said, and used for training of trainers and face-to-face. But then also for communities who preferred online access, and for workers who are not able to join, they were also able to take the training online. So it was more like you could choose the modality you wanted, online or in person, for this field worker training on clinical management, and also in the language that's easiest for you. Another one that we've looked at is local dissemination. So for example, we have country offices who have really been champions for making sure that the materials are reaching all local communities. And I know in Vietnam, for example, they distributed all the courses through the family physician network. And that was a way for them to be able to move the courses forward. And I'll mention one more. So we have a partnership with our Pan American Health Association office in the Americas, and they have their own virtual campus for public health platform, which is mostly where they have courses in Spanish and Portuguese. And we've partnered with them to actually have all of our many of our OpenWHO courses translated into Spanish and Portuguese and then hosted on both platforms, so that we're able to reach additional audiences who might not know of this global platform but are familiar with the regional platform from their offices. So Yeah, I think I'll leave it at that and see if we have any questions. But thank you so much for your attention.
We thank you for your great presentation. Any questions? If not, I just want to make some comments.
We have in the room, so we can take it from here. Yeah, go ahead.
It's not a question, it's, consider me ignorant. But if I'm someone who is registering in one of the online courses, so I finished the course, what am I getting out of it? Is this going to qualify me for some credit at the university? Is it what's it doing? The learning, okay, I get it. Great, it's always nice to learn. But what am I getting if I'm a student who's registered in these courses other than the Skillshare approach of I've got a course?
Yeah, so these courses are really continued education for health professionals mainly, or public audiences who want to protect themselves from mainly infectious diseases, also other health events. We do have the continued professional development accreditation for some courses, and the humanitarian pass H-pass accreditation for other courses. So there's kind of that if you are a health workforce and you need to verify, like the medical personnel actually have to take credited courses every year. You can do some of that. However, these courses like COVID-19 vaccine rollout for least developed countries, we had a course for these countries, like Ghana received the COVID-19 vaccines early 2021 as a first donation vaccine receiving country. We had a 8-module vaccine rollout course developed with cold chain, with everything, so that the logisticians could use this information. How now I roll out the AstraZeneca or Pfizer vaccine. So this is a additional to your already existing professional knowledge, which gives the real-time learning component for you to utilize to respond to this outbreak, epidemic, or pandemic that is at hand. But we have a couple of courses with the CPD accreditation, not many yet. We have just started. We actually started it early this year. We are rolling it out for more courses so that our workforce can then also get accredited. We noticed a few universities actually from this continent had required their students to complete our courses, and when they had you've completed your occupational health and safety or return to work, safe return to work, or office after COVID-19 courses, then they got the mark, it's done. But it's not, we don't have like the European credit transfer system, point system, or anything like that. This is really a option for professionals to take and fine-tune their knowledge on a specific topic to help respond to events.
So then my follow-up is, it would have been, I guess you're all working on these courses becoming part embedded in medical schools and whatever as
as United Nations, we are not to go and compete with the formal education. So the formal education by medical universities, public health universities, others is always there as the starting point for your professional career. Then we come here in with the real-time guidance-based introduction, like, okay, in this maternal ward, how do you protect without clean water? How can you protect this event now, this patient? So this is a needs-driven kind of a response from United Nations Health Agency to those who need to learn in quite a complex conditions. And I think our first and foremost audience is really the vulnerable countries or collapse states. And for instance, in the Eastern Mediterranean region, we have many of them. We really target these audiences, and we are happy, as Melissa showed, 70% of our use case, 70% and more of our use cases in the low and middle income countries. Everybody's open to come and join, but these are not particularly targeted for Finland, like my country, who has already resources for their health workforce. Yeah, thanks for that. Lovely. I think we're good here. Thank you, Chair. Over to you.
Thank you.
Thank you.